Hi, I'm Matt Cooperberg from the Departments of Urology and Epidemiology and Biostatistics at the UCSF Helen, Diller Family Comprehensive Cancer Center in San Francisco. And it's a pleasure to share some thoughts with you today about the topic of getting under the hood of racial disparities in prostate cancer, which is an area of growing importance in research. And I think a lot of the lessons which are evident in prostate cancer have pretty broad applicability across oncology. So just to start off here, painting a picture of the epidemiology and where prostate cancer stands in 2020. It remains by far the most common cancer diagnosed among men, with over 191,000 diagnoses expected this year. It also remains the second most common cause of mortality among men, over 33,000 cases expected to be lethal. Now, of course, the number of diagnoses still far exceeds the number of lethal cases. And it's really important to look at the way these trends have evolved over the years, because this is the background against which the disparity story needs to be understood. So the incidence of prostate cancer has varied quite a bit over the decades with practices around PSA-based early detection. So in the early 1990s, when PSA really hit the clinical forefront, incidence spiked as a whole set of prevalent cases which had been undiagnosed in the community were suddenly diagnosed. Then a steady state was found throughout most of the 90s and early 2000s. And then after a series of recommendations from the US Preventative Services Task Force, cast a increasingly cold bucket of water on the PSA screening program across primary care in the US, incidence rates plunged to the lowest level in 2014 that they had seen since the 1980s. Now, this, of course, is not because prostate cancer had disappeared from the population. If anything, men in the 2010s are living longer than they were in the 1980s. They're less likely to die early of cardiac disease. We should be seeing more prostate cancer, and yet the incidence rates plunged. And this was really because of profound drops in PSA early detection programs after first the 2018 and then 2012 recommendations from the USPSTF. Mortality rates in the meantime, where we have data going back to the 1930s, had really been very slowly rising throughout the 20th century, really peaking around 1990 to 1995 or so, and then had been falling pretty progressively over a 20-year period at the fastest rate of any cancer except for lung cancer. Now, we know this decline in lung cancer is attributable almost entirely to smoking cessation programs. The decline in prostate cancer is a little bit controversial, but there's really little argument that at least 30 to 50% of this decline is directly attributable to early detection programs. And it's concerning that in the most recent years of the data, we actually see the mortality decline stabilizing or perhaps even reversing for the first time. This is not entirely due to the drop in screening, but there's no question that as mortality rates increase, if we continue to drop down in terms of screening, we will see more prostate cancer mortality. Now, why is this important for disparity? Well, over all these years that we have seen the ups and downs of incidence and the decline in mortality, we have very consistently, year after year, seen a very substantial racial disparity whereby African-American men compared to Caucasian men have consistently borne about a 2.5-fold increased burden, not just of prostate cancer diagnosis, but of diagnosis with metastatic and ultimately lethal disease. And this has really not changed much year after year, decade after decade. From 1970s to the mid-2000s, this rate ratio varied up and down a little bit, but really never fell substantially. Even as mortality rates did fall among African-American men and Caucasian men, the gap really has not narrowed very much. Now, as many things in epidemiology, the devil is often in the details. And when we drill down below the national level, we actually see pretty profound variation in these trends over time. This was a nice study looking at 50 different urban areas across the US, comparing mortality rates in the 1990s to the late 2000s. And what this is looking at is the change over time for Caucasian men in the white circles here and African-American men in the black circles here, and looking at the delta, the difference over time. So for example, in San Francisco, my city, this is a fairly typical case where there was about a 44% drop in mortality for white men, 43% drop for black men. So there's a comparable decline, but really no change in the delta, no change in the gap between the groups over the years. But you can see some extreme counterexamples. In Minnesota, for example, in Minneapolis, the mortality rate fell about 30% for Caucasians, over 70% for African Americans. So here there's a pretty substantial narrowing of the gap. At the other extreme, in Oklahoma City, mortality rates fell about 40% for Caucasians and actually rose 8% for African American men. So a substantial widening of the gap. And of course, a lot of this is random variation. This is not, nobody's saying that there are specific programs that we can point to in one city or another which explain this. A lot of this is statistical noise, but it's still important to really understand the local patterns of wherever one lives and practices in terms of trying to understand what is going on in the local populations. Now, there's a paper that came out just a couple months ago, again, looking at SEER data, which suggests that in the most recent years, we may be seeing a little bit of progress. So this is the mid-2000s up through the mid-2010s, showing that this rate ratio has been declining over this time period from about 3 to around 2.5 for men 50 to 74. And for older men, we've seen a similar decline. Now, this may be a true decline, although if you think back to the graph that I showed earlier, the rate ratio has varied over the years between 2 and 3. So this may just be a little bit more, natural variation within the consistent range that we've seen over the decades. Now, to an extent, it seems to be the case that prostate cancer actually follows a similar trajectory among African American men as it does among white men, but that it starts about 5 years earlier. This is a paper from a set of models run by the CISNET group. This is a group of statistical modelers funded by the NCI and the Prostate Working Group, who have been really focused on nothing but understanding the PSA observed incidence and mortality data through the lens of screening programs for nearly 30 years now. It's investigators from the Fred Hutch in Seattle, led by Ruth Etzioni, by a group in Michigan, and a group in Erasmus in Rotterdam, who have all been looking at the observed data through different mathematical models. And all three models gave a fairly consistent output, a consistent story that, again, the trajectory may be similar, but the onset of prostate cancer, the first growth of the cells, and ultimately the clinical presentation appears to be about 5 years earlier on average for Black men compared to white men. And we see this if we look at the rate ratio data, the increased burden borne by Black men compared to white men. This is looking across time now, not over time. We see that by far the highest rate ratios are seen for the younger men. Okay, so for men in their late 40s, African American men actually have a 4-fold higher likelihood of being diagnosed with metastatic disease compared to Caucasian men. And as men get older, the gap narrows, ultimately flattening out around a 2-fold higher rate of metastatic disease for men by the time they get to their 80s. Again, suggesting that a large part of the explanation for the excess burden of disease borne by Black men may be seen in the fact that the disease starts earlier, and it's really younger African American men who are in fact at greatest excess risk. So nothing that I've said so far is really at all controversial. It's been widely recognized for a long time that prostate cancer is worse among African American men. African American men get more prostate cancer, they get more high-risk disease, and ultimately more lethal disease. But none of the data, none of the studies that I've shown have really gotten at the important question, which is, why is this so? And there's a nice framework for thinking about what health disparity research should look like, which proposes 3 phases of disparity research. Phase 1 is identifying that a disparity exists. Phase 2 is elucidating the underlying causes of the disparity. And phase 3 is developing interventions to try to ameliorate this disparity. And the fact is, we've really been stuck in phase 1 pretty much forever in prostate cancer. We are just starting to dip our toes into phase 2 and really have not begun to scratch what should ultimately be phase 3. So, what are at the roots? What can we say in phase 2 that can potentially explain what we know to be a very substantial disparity? Well, the obvious potential sources of explanation here are genetic factors, environmental factors, and then structural factors, which are basically access to care and the quality of care delivered. Now, of course, there's multiple sub-levels of investigation here in terms of environmental factors. Well, it's an incredibly broad category that is things like diet, smoking, allostatic stressors. It's also things like neighborhood factors, structural bias within the healthcare delivery system kind of falls under access to care. So are African-American men able to get screening? Do they have the right information about screening? If they get screened, do they have access to high quality urology care and diagnosis? Is treatment done appropriately, and is it of high enough quality? And then also under the access domain are structural issues such as well-founded mistrust in the healthcare system, other issues with structural racism in areas of public health, et cetera. And the problem is most studies tend to be fairly reductionist. They focus on just genetic factors, just environmental factors, just access factors, when in fact the truth is almost certainly all of the above. And it's also true that when we look at studies of prostate cancer incidence, or in particular studies of prostate cancer mortality, the more factors we put into a multivariable model, the more likely it is that race itself will drop out. Meaning that we can find the explanation here. It doesn't mean that there is not a racial disparity. It means that it's really not about skin color per se, and it's probably not even that much about biology. It's about all the things that go into race as a social construct that really drive the excess burden in terms of race for prostate cancer. There may be some biologic differences. This is a brief study that just came out in the New England Journal recently, looking at some publicly available genetic data, and they did find some differences across race. This was looking at Asian, white, and Black men in terms of the total mutational burden. Actually, the highest burden was seen for Asian men here, and you do see some differences in specific genes if you look hard enough. Perhaps more actionable genes, although that's fairly moving target in terms of what that term means among Black compared to white or Asian men. But I don't think any of these data or similar studies would support a statement that there's anything fundamentally different about the biology of prostate cancer among Black compared to white men. There are some differences here, but they're relatively subtle, and none of these, again, would suggest that we are dealing with fundamentally a different biology. So there may be an answer to be found in screening. If you look at the screening guidelines in 2020, we do see a gradual convergence over or beyond what has been a very controversial and divergent set of guidelines over the years. So the U.S. Preventive Services Task Force, which I mentioned earlier, is by far the most influential body when it comes to driving screening decisions and screening recommendations by primary care providers to their patients. So in 2012, the USPSTF recommended that nobody should be screened ever, regardless of race or family history or any other risk factors. Now, as of 2018, they recommend shared decision-making for men 55 to 69, and they recommend against for men over 70. They have no specific recommendations for African-American men. There's some text in there calling for more research, although the prospect of getting a randomized screening trial specifically focused on African-American men is extremely low. And even if such a study happened, we would not get results for 20 more years. This 55 to 69 age range here is, by the way, is not based on any evidence to suggest that that is the optimal time to screen. The reason that age range is recommended is that there's really only one large multi-center randomized trial, which actually addresses the question of screening versus no screening. It's the ERSPC, a large multinational European trial, which has read out its results over the years. And in that trial, the core age range for randomization was 55 to 69. So that is the reason that this age is the basis for the USPSTF's recommendation. It's almost certainly not optimal. There was another trial which included men 50 to 55, which actually had better results than the RSPC, which was not included here. And it is very likely the case that screening earlier makes the most sense. So the AUA, the American Urological Association, now is actually relatively similar to the USPSTF in also recommending shared decision-making for men in the same core age range, 55 to 70. They don't really make any recommendation for younger men. They recommend against for older men. And again, no specific recommendations for African-American men. Now, the other guidelines, the NCCN and the American Cancer Society, are both based on a broader consideration of the literature rather than focusing just on the randomized trials. They recommend shared decision-making again for a broader age range. The NCCN recommends for men 45 to 75. ACS recommends starting at 50. ACS explicitly recommends starting about 5 years earlier if there are risk factors, even 10 years earlier if there's multiple risk factors, including African-American race. So African-Americans with family history, where you start to get multiple risk factors, this is where you really want to think about starting at 40. The NCCN is a little bit less crisp, but they do recommend starting screening several years earlier, again, for African-American men. So what about access? What do we actually see in terms of screening patterns for Black compared to white men? This may actually be a little bit of good news, and these studies have been done repeatedly over the years. The fundamental message here is still not great news if you ignore disparity for a minute, which is that the most common age for screening in America is still late 60s and early 70s, and this is not the right time to do screening with PSA. Men by this age tend to have BPH. They tend to have many competing sources of PSA. And this is an age where we see a lot of over detection of low risk disease, under detection of high risk disease, and ultimately over treatment and under treatment as well. By far the best time to use PSA is in late 40s, early 50s, maybe even up to age 60, where PSA with a lower threshold is much more specific for prostate cancer specifically. And this may actually be a bit of good news within this overall problematic screening pattern, which is that Black men are actually more likely to be screened at younger ages than white men, a little bit less likely to be screened than white men at older ages. So this is less under-screening for younger men and actually less over-screening for older men. So, so this is actually likely a favorable trend, I think, reflecting an understanding over the years that Black men are at higher risk and should be potentially screened earlier. The problem, though, is that this 20%, 30% rate here is still much too low. And if we want to make a difference, we probably need to drive these rates up, specifically in the younger age ranges, quite substantially. And there is a rationale to think that a large portion of the disparity could be ameliorated with a more aggressive early detection program directed specifically at African-American men. It's important to note that when we talk about early screening, we need to forget all about 4.0 as the threshold to drive further evaluation. So 4.0 was chosen because when PSA was developed as a screening test, most men in the screening studies were in their 60s, just as in this study here. The fact is, for younger men, for men even up to age 60, the median is around 1.0. For men in their 40s and 50s, the median is 0.7 or 0.8. And this has been shown very consistently across multiple studies, multiple ethnicities, multiple countries. So the median for men in their 40s is around 0.6, 0.7. In your early 50s, around 0.8. By the time you get to 60, around 1.0. And again, this is identical for white men, Black men. There's a large study out of Japan, which again shows exactly the same median PSAs. So what this says is that with a single PSA test before age 60, we can pretty much rule out prostate cancer for at least half the population and probably even more. These studies summarized here looked at long-term outcomes after a single baseline PSA going out to 10, 20, 30 years and found that this single baseline test was highly, highly predictive. So men under the median or even under the 75th percentile in many cases can basically not worry about prostate cancer. But men above median, basically above 1.0 is a good way to remember it, need to at least think about workup with secondary tests, not necessarily with biopsy, but either with more careful monitoring going forward or with workup. Now, what about treatment? Do we have evidence of any sort of bias or discrepancy in terms of access to high quality treatment? Well, this is a look at the likelihood of receiving definitive treatment as opposed to no definitive treatment. And what we see is over the years here, from 2004 up to 2013, higher rates of expectant management or no definitive treatment for African-American compared to Caucasian men in a large study out of the National Cancer Data Bank. Now, the NCDB is focused really in hospital-based care, so this is going to under-capture active surveillance done in the community setting. And this is not particularly risk-adjusted, so it's a little bit hard to know, but this is suggestive perhaps of more under-treatment among African-American men. There was a study reported last year using a new SEER sub-database focused on watchful waiting, which looked at the odds of receiving active surveillance for low-risk prostate cancer for Black versus other men. They found variation from year to year, suggesting in 2000, they concluded in 2015 there was a drop in the use of surveillance for Black men, but this was really an insufficiently adjusted study. And a follow-up paper, which is going to be coming out in press relatively soon, shows that with further adjustment for other factors like income, education, access to healthcare providers in the community, specific geographic location, Black versus white race drops out completely. The hazard ratio here is 0.99. There is really not a hint of a difference between the two groups. If anything, it's actually Hispanic men who have a lower risk of lower likelihood of active surveillance for watchful waiting compared to the other groups. And the other story here is that any sort of racial difference is really swamped by just raw variation. This is looking at the different SEER registries, registry by registry, and within the registry is the individual counties. And the county level variation really swamps everything. And we've known this to be a problem for many, many years in prostate cancer care and elsewhere in the healthcare system. What you get depends far too much on whose door you happen to knock on in terms of which doctor you wind up seeing. And getting at this variation problem certainly has to be part of the project in terms of ameliorating disparity at the level of race. So the prior analysis raises the question, is the disparity really driven by race, or is race just reflecting poor socioeconomic status, reflecting structural racism, et cetera, but basically is it an economic problem rather than a race problem per se? For one look at this, we looked years ago at the San Francisco General Hospital population, which is the safety net hospital serving San Francisco County, compared to the university practice at UCSF, and compared to a large registry called CAPTURE, which tracked men diagnosed with prostate cancer across 25 urology practices across the United States. And this is a look at the risk profile. So 0 through 9 here is what we call the CAPRA score, low, intermediate, and high risk prostate cancers. And over here on the right is advanced disease at the time of diagnosis. And in short, the men presenting at SF General Hospital had a 3-fold higher rate of presenting with advanced disease than those in the CAPTURE database, and much higher likelihoods of intermediate and high risk disease, despite the average age being about the same at the general, and the screening rates, PSA diagnosis being fairly similar. But this was true in a very mixed race population. So the SF General population certainly has more Black men than CAPTURE or the broader UCSF population, but we saw this across the Asians, across the Caucasian patients in this hospital, Hispanics. It was really seen across all the different race groups, this high prevalence of high risk and advanced disease. Now, it's also worth stepping back away from the United States for a minute in terms of trying to gain some insights from global epidemiology in terms of prostate cancer, because prostate cancer is increasingly a global disease. We used to think of this as a disease really just affecting men in the developed world who would live long enough to not die from infectious diseases or violent causes, malnutrition, et cetera. But as the world is developing, it is more and more of a concern internationally. Prostate cancer is now one of the higher causes of incidence internationally, almost 10 million cases a year anticipated, and it has now passed esophageal cancer to be the 5th leading cause of cancer mortality around the world. But of course, incidence varies dramatically with geographic locale. Now, what's interesting is if you look at the incidence data, they really do tend to track with screening rates. So the developed world tends to have higher rates of incidence, although there are certainly hotspots in the Caribbean, for example, in Brazil, South Africa, where we see exceptions here. But what's interesting is that the incidence data and the mortality data have relatively little association with each other. So there are some countries, Sweden, for example, which screens heavily, but still has a relatively high mortality rate. The story in the US is fairly typical of what we would hope to see with a screening program, which is heavy screening, tends to drive down mortality rates. And then if we look for the highest mortality rates for prostate cancer in the world, we find them in areas with relatively little screening, specifically in sub-Saharan and West Africa. And in the Caribbean, we see high incidence and mortality. And if we look at the highest mortality rates in the world, many of these countries are in the Caribbean. So it's the combination, we think, of countries where there's a high population of West African origin and relative economic development compared to the actual West African countries. So the men have the opportunity to live long enough to potentially get lethal prostate cancer. And this is really where we're seeing these rates, which are truly off the chart if you compare them to the US, where the age-standardized mortality rate is about 7.7. We're seeing rates as high as 7 times that rate when we look at some of these Caribbean countries. And again, there is little bearing here, little association consistently between development index and mortality rates. This is just one more look at this association or poor association, lack of association between incidence and mortality. So we know that environmental factors bear heavily on prostate cancer incidence and mortality. Prostate cancer has been associated quite clearly with smoking rates, with certain poor dietary habits, high inflammatory diet, high fat diets have been associated with prostate cancer. There's also the question about stress and cancer. And there's very poor or weak data here for prostate cancer specifically, but there have been some, at least in vitro studies in mice and cell lines. The mice, this is sort of a classic example of just stressing out the mice by putting them just in crowded living conditions, crowded cages. The same mice tend to get more cancer. Now, this is this concept of allostatic stress. Many of us lead stressful lives, we have a lot of things going on in life, but I'm guessing that most of you watching this video, like myself, if I quit my job tomorrow, I wouldn't starve and my children would not lose the roof over their heads. And that is not the kind of stress that we think is carcinogenic. It's the allostatic stress of day in, day out uncertainty as to one's security and future that we really think are bad. You know, the chronically elevated cortisol levels, derangement of various genomic pathways, inflammatory cascades, none of which is all that well defined, are likely factors to be considered and certainly need much, much better study. So finally, the question has come up whether African American men should be offered active surveillance, which means not treating aggressively immediately at the time of diagnosis. And this controversy has been raised. I alluded to this before with the treatment data. This really came up with a couple of studies out of Johns Hopkins, which found that if you take African American men with low risk disease and who went straight to surgery and look at the likelihood of finding more aggressive cancer at the time of surgical pathology, these likelihoods were much, much higher for African American men compared to Caucasian men, about 5-fold higher likelihood of adverse pathology and 4.5-fold. And this was even after adjustment for other factors. And a follow-up paper suggests that African American men have more anterior tumors, which are more likely to be missed by prostate biopsies because those are typically done transrectally, so through the rectum to the peripheral zone of the prostate here. The problem is this has really not been validated in other studies. So we looked at the UCSF cohort and at the CAPTURE study, which admittedly has a relatively small proportion of African American men, and found that if we looked at upgrading, upstaging, there was really no impact of race once we adjusted for other factors. There was a slightly higher rate of positive margins, but that is not really the same finding as what Hopkins showed. We also looked in the SEARCH registry, which is a multi-VA registry with a much higher proportion of African American men, about 40%. And again, adjusting for other factors, race drops out of the model. Doesn't mean that African American men don't have worse disease. It just means that that disease is adequate, that increased risk is adequately captured by the standard parameters like Gleason score, PSA, margin status, et cetera. And for African American men that actually start on active surveillance, again, the Hopkins data did show an increased risk of reclassification to higher grade disease, about 1.5-fold higher risk by the hazard ratio, which again has not been replicated in other cohorts. This is the multi-center Canary cohort, which found that race dropped out again with adequate adjustment. So what explains this? We don't really know. And this really goes to the point, again, I've alluded to this a couple times in the talk, that race is really a social construct, not a biologic one. And we say, you know, we use the term African American for a wide range of genetic and genomic heritage. Even looking at the mean proportion of African ancestry across the country, you see huge ranges. And of course, Africa is a big place, and specific heritage within Africa will drive different genetic risk potentially, if genetics explain at least a part of the disparity. So maybe there is something unique about the population around Baltimore served by Johns Hopkins. Perhaps it's just a statistical fluke. Certainly something that bears further investigation. And final comment, when we look at distal endpoints, meaning actual cancer-specific mortality, we again find across multiple registries, this is SEER, this is a set of different randomized trials, multi-center VA cohort, that with adjustment, African-American race tends to drop out of the models. Again, not to say that the disparity is not very much real, but only that it is that the increased risk is reflected. We can find it in the standard disease characteristics. So to sum up, there is no question that African-American men face much higher rates of prostate cancer, both in terms of incidence and mortality. The explanations remain really poorly understood. They are almost certainly multifactorial, reflecting some combination, which we still do not understand, of genetic, environmental, and health system factors. And it's the interactions among these factors that are really crucial to understand. But we really need to recognize that the disparity is certainly more than just skin deep. And if we want to eliminate the observed racial disparity, we probably have to address more than a single factor. There is, again, no argument that African-American men face earlier mortality and should be offered screening, likely at an earlier starting age. 45 is probably a reasonable target, using a threshold of 1.0 at that age to merit further workup or at least closer surveillance. But again, after diagnosis, race tends to drop out of most of these models, which is reassuring, at least to the extent that the parameters that we know predict outcomes like PSA, Gleason score, stage, etc., are no less germane to African-American men as they are for Caucasian men. So this is an area of both substantial clinical importance, social importance, and also an area really, really ripe for high quality research going forward. And we really look forward to the future developments here. So thank you very much for your attention, and hope to see you at a future session.